Good morning, and thank you for that very kind introduction. I have no disclosures. I wish I did. Okay, so why do we have this problem? Well, one of the reasons is that we really don't have a clear definition when pediatric care ends and when adult care begins. Probably if we ask everybody in this room, we might come up with 5, 6, 7, maybe 10 different answers. And so what pretty much happens is inertia, right? Kids start out in pediatric care, and then they just kind of continue until they're somehow forced out of the system. So 2 years ago, the American Pediatric Surgical Association surveyed their membership, so a bunch of pediatric surgeons, and said, oh, how old are the kids that you're taking care of? And it turned out that over half of all pediatric surgeons are taking care of patients older than 22 years old. And I think if you ask anybody, 22 people would say, yeah, that's probably an adult. I mean, that's graduated college. So then they said, well, what are you taking care of them for? And 4 out of the top 5 reasons why they're taking care of these patients are actually colorectal reasons. But a lot of these are congenital anomalies, and some of them are sequelae of congenital anomalies like chronic constipation. So the next question then was, okay, why are you still taking care of these older patients? And the top reason why was the pediatric surgeons felt that lack of qualified adult surgeons was the main reason why they were not transitioning. There were a whole host of other reasons, and I was actually really surprised to see that insurance was the last one on the list. So do adult surgeons need to get ready to take care of pediatric patients who are graduating into adulthood? And these are projected numbers of how many patients with congenital anomalies are going to hit adulthood. And you can see the numbers are growing very quickly. And in about 20 years, there's going to be tens of thousands of adults who have had major congenital anomalies, surgical anomalies that have been fixed, who are going to need ongoing care. So, as Danielle said, last year we partnered, the American Academy of Pediatrics section on surgery partnered with SAGES to survey your membership. Now, the response was very small, only 49, but I think the responses are actually interesting to look at because the data are helpful. So the 49 members who responded represent 22 states, and more than half of them were in practice for greater than 10 years at the time they responded. So these are not young, people straight out in practice. 80%, this is probably a skewed view, 80% are in training programs. I was very happy to see that over 90% of the respondees would see a young adult who had previous surgery. And we asked the question, in the last 5 years, have you seen an increasing number of young adults? And about half said no, and slightly less than half said yes. And I would expect if we resurveyed people in 10 years, these numbers would look very different, that the majority would probably say yes. So we said, how many young adults with previous surgery have you seen in the past year? And more than half of the group that responded had seen 1 to 10. So a very small number, but again, that's going to be a growing number. Again, very happy to see this result. We said, if you do have a young adult with previous surgery come see you, do you have a pediatric surgeon in your area with whom you can consult? Most said yes, so that's great. And then we said, okay, how do we help you? What types of information and knowledge, what's the knowledge base you need in order to take care of these patients effectively? No surprise, it's surgeons, so operative techniques came out number 1. But they were also interested in learning what these kids' long-term outcomes would be. And in essence, they're a little bit undefined because these kids haven't had super long-term outcomes. In pediatrics, long-term outcomes is 10 years, 15 years. So long-term outcomes, that's really yet to be defined, and we do rely on our adult colleagues to help us define that. All the way at the very bottom of the list, embryology. Well, that happened so long ago, it's probably not terribly relevant anymore after the surgeons have gone and changed all the anatomy. Then we said, okay, if a young adult is coming to your office, what should they bring with them that's going to make it easier for you to take care of the patient. Operative reports, X-ray images, CT scans, MRIs, and talking with the pediatric surgeon who's sending them. Those are the most important. Imaging reports, clinical notes, and discharge summaries, all less important. So when I look at this and the prior slide combined, I look at that and say, okay, well, that's really the responsibility of the sending physician, right? The pediatric surgeon, the hospital that the patient's graduating from, or the health system's responsibility to help the adult side catch these patients in a safe way. And so these are the things that we need to provide our patients to take with them to the adult surgeon. And on the prior slide, those are the things we need to educate the adult surgery membership community on, so that when the patients do come to them, they have access to that knowledge. And this was another slide that I was actually happy to see. This was surprising to me. We asked what the barriers are to taking care of young adults to the SAGES membership. And surprisingly, almost half of the respondees said, we don't have any barriers. Now again, it's a little bit of a skewed representation because 80% of the respondents were from training programs, so I think of that as tertiary quaternary environments with a lot of resources. But really, in the 20 or 30% zone, you see things like the different medical subspecialties and surgical subspecialties, and the minority of respondents actually said that those would be barriers to accepting a young adult into their practice. So I'm going to wrap up there. What I'm very excited to hear today is my expert pediatric surgeon colleagues here in a whole variety of pediatric surgical conditions and what the issues are as those specific patients graduate up into adult care. And what I would like to hear from all the non-pediatric surgeons in the room is how else can we help you take these patients into your practice in a way that you're comfortable and that you have access to pediatric surgeons or knowledge bases so that these patients can continue into the adult continuum without a bumpy road in transition. So thank you very much.